Hello, everyone. We're going to get started. And thank you for joining this important webinar on the mental health needs of LGBTQIA plus youth, what parents and others need to know. For those of you who have been attending our webinars in the past, you know the drill. You're going to hear some information you've heard before. I'm Sarah Dinklage, the Executive Director of Rhode Island Student Assistance Services. We at RISAS, in partnership with the Rhode Island Department of Health, are proud to bring you this series of webinars focusing on youth mental health and the ways educators and parents can foster resilience in their children and students. Located below this video, you'll see a description box with links to our website and Facebook page where we will let you know when more content like this will be released. In addition to these items, we have created a post survey to get your input on the contents being provided. After completing the survey, you also have the ability to receive contact hours for your time spent watching this presentation. There will be a reminder towards the end of our video to take the survey for a chance to win a $100 gift card. As the mother of a gay man who just married the love of his life on June 5th, I am cognizant that it was not long ago that ceremony of love could not have happened and the toll that would have taken on my son's well-being. Not being accepted for who you are and who you love creates enormous mental health challenges in our youth. Our presenter, Dr. Keuroghlian, is an associate professor of psychiatry at Harvard Medical School and co-director of the Harvard Medical School Sexual and Gender Minority Health Equity Initiative. He directs the National LGBTQIA+ Health Education Center at the Fenway Institute, an organization dedicated to improving care for LGBTQIA+ people across the US. Dr. Keuroghlian also established the Massachusetts General Hospital Psychiatry Gender Identity Program. Thank you again for your interest in this topic, and I'm now pleased to turn it over to Dr. Keuroghlian.
Thank you so much, Sarah. I appreciate that, and congratulations on your son's wedding. That's wonderful. Great to be with you all today. Thank you again for this opportunity to connect with this really remarkable community and to the organizers for this event. I enjoyed a couple months ago doing a similar presentation specifically for educators. So delighted today to be connecting with parents and families. And I look forward to having this be a dialogue. Please feel free to pose questions. And I think we're going to have some time at the end of the session to discuss and to answer those questions of yours. So definitely keep them coming and we'll get to them in due time. I'm going to start by defining some important concepts and terminology related to sexual and gender minority populations and youth. We're going to talk about the relationship between stigma and inequities experienced by sexual and gender minority young people, LGBTQI+ people, and we'll describe some best practices related to effective communication, creating inclusive and culturally responsive environments at home, in our communities, in our schools, and in spaces generally that our youth live in and hopefully thrive in. First big point to make, admittedly, there are a lot of concepts and terms that get used when we first start focusing on LGBTQI+ youth, our own children and their friends and communities at school. And these can be often overwhelming and confusing initially. So let's walk through some of these concepts and terms together slowly to make sure we're all on the same page. The first big point to make is that sexual orientation and gender identity are not the same thing. These are two different concepts, two different experiences. Everyone has both a sexual orientation and a gender identity. Each of us on this Zoom session, for example, has one of each. And how a person identifies in terms of sexual orientation or gender identity will evolve throughout the lifespan. A young person may initially identify as straight and later identify as gay. may initially identify as a girl and later identify as a boy, for example. This is why, for example, in healthcare, which is how I come into this, we ask about sexual orientation and gender identity as health relevant demographic variables, not just once where we check a box after the patient tells us, breathe a sigh of relief, and never discuss it again. We check in at least every year, if not every 6 months, with our young patients about their sexual orientation and gender identity, because we know that this is a dynamically evolving demographic variable that's very relevant to their health and wellness and well-being. It should also be said that the concepts and terminology we use now are different than the ones we used 20 years ago, 10 years ago, 5 years ago, even a year or two ago. I'm hearing new terms, particularly from my very young sexual and gender minority patients in the last 4 to 6 months, say, that I hadn't heard even a year or two ago. So part of this is a very rapidly moving linguistic and cultural revolution that can be part of why this may seem overwhelming or daunting for parents and families to keep up with. We'll talk a bit about how to do that. So I find it helpful, rather than keeping up with the latest specific terminology necessarily, to remain grounded in certain basic foundational concepts that'll serve you well. The first helpful concept is the idea of sex assigned at birth. When babies are born in most countries and cultures around the world, they're typically assigned one of two sexes based on physical characteristics, right? Female or male, and in some cases intersex if they have characteristics or features of sex development that are beyond traditional societal expectations for female or male bodies. We now know that these babies grow up, become children, adolescents, and eventually adults who may have a gender identity, core fundamental inner sense of their gender, that doesn't align with society's expectations based on the sex they were assigned when they were born. So what is gender identity? It's a person's inner sense of being a girl or woman, boy or man, something else beyond girl, boy, or beyond woman, man, or having no gender at all. All people have a gender identity, and it's important to note that we also appreciate many people have a gender identity that doesn't fit one of the two traditional options that exist in society of either being a girl or being a boy, either being a woman or being a man. So we increasingly acknowledge that many people have what we would refer to as a non-binary gender identity, beyond the two traditional binary options of girl or boy, woman or man. And we'll talk more about that today as well. So that's gender identity in a nutshell. It's a very core, fundamental inner sense of your gender. Gender expression is how a person presents or communicates their gender to other people, to the outside world. And this can be through a young person's mannerisms, their voice, the way they walk, the way they dress, their hairstyle. And it's important to note that gender expression is quite complex as well. It's not necessarily the case that a young person assigned male sex at birth would want to or ought to express their gender in a traditionally masculine way, whatever that means. And it's not necessarily the case that people assigned female sex at birth would want to or ought to express their gender in a traditionally feminine way, whatever that means. It's also contextual. Someone may have, say, a more feminine gender expression at school and a more masculine gender expression at home. It's cultural. What's considered feminine or masculine in one culture is not necessarily considered the same in another culture. And the reality is that each of us have aspects of our gender expression that are traditionally masculine and also that are traditionally feminine. We all have a bit of each. So just to say, finishing this before we move on, and we'll talk more about both of these concepts today, we can't predict someone's gender identity based on their gender expression, based on how they look or how they sound. So an important part of all of this is self-identification. We have to ask people how they identify in terms of their gender, not make any assumptions based on what we see or hear, and honor what they tell us in terms of their gender identity. And we'll talk more about that today. Now, it may seem like people with non-binary gender identities, which I mentioned earlier, would be a very small fringe subpopulation, say, within the transgender community. And it turns out that's not at all the case. This is a study we did with 452 people in New England. We found that 41% of these 452 transgender people identified as having a non-binary gender identity. That's a large proportion. And a large national study of 28,000 people across the country found that 35% identified as non-binary. And the younger and younger you go within the US population, the more and more likely people are to identify in general as LGBTQIA+, So in Gen Z, I think it's something like 16% of the US population that identifies as LGBTQI+. People are also more and more likely to identify as non-binary in terms of their gender identity. So what's happening? Is this a social fad or trend? Not at all. It's that we're now making room for the naturally existing, naturally occurring diversity in terms of sexual orientation and gender identity that exists among humans, that's always existed, and that now in modern Western society, we're just starting to make room for, although in many countries and cultures and civilizations throughout history, more or less room has been made for the reality of naturally occurring human diversity with regard to sexual orientation and gender identity. And we're going to keep kind of evolving and refining and having more nuanced ways of characterizing and describing this, and for people to identify in these ways. And we're seeing that in terms of demographic survey data now in the US just in the last few years. We have many resources on our website at the National LGBTQIA+ Health Education Center at the Fenway Institute in Boston that are all available for free. You can download them and watch our webinars and access our briefs. This is one of the many briefs on our website. We developed these for the US Bureau of Primary Healthcare. This is on providing affirmative care for patients with non-binary gender identities. And this is a PDF you can download for free. A little more about gender identity related terminology. What does the term transgender mean? It's an umbrella term for people whose gender identity doesn't align with society's expectations based on the sex they were assigned when they were born. For example, for people with a binary, more traditional gender identity, if someone is assigned male sex at birth and identifies as a girl, they may refer themselves as a transgender girl, as a trans girl, simply as a girl, and not identify as transgender or trans. If someone is assigned female sex at birth and identifies as a boy, they may refer themselves as a transgender boy, trans boy, simply as a boy. And in terms of non-binary youth, many people will identify as non-binary. That's a term that they'll use. Many people identify as gender queer. And we also hear the term gender fluid, which implies a gender identity that's more dynamic and potentially going to evolve over time and fluctuate or change over time. We also increasingly use the terms transmasculine and transfeminine. These are terms that are more inclusive of people with a non-binary gender identity. So a transmasculine person is someone assigned female sex at birth who identifies more with masculinity than with femininity. They may identify in a traditional binary way as a boy or as a man, or they may not. But that was gender identity and gender expression in a nutshell. I'm now going to talk about sexual orientation, which is a separate concept. And sexual orientation refers to how a person identifies their physical, emotional, and romantic attachments to other people with regard to gender. And it's helpful to think about sexual orientation in three components. The first component is desire. This is whether someone is attracted to other people and the genders of the people they're attracted to. When I was in medical school, I was trained to ask patients, are you attracted to women, men, or both? We've now moved beyond that. We ask, who are you attracted to generally, or what are the genders of the people you're attracted to make room for the fact that there are more than two possible genders. In fact, we take one step back from that and we ask, are you attracted to other people? To make room for asexual and aromantic people who may not, by and large, experience attractions to other people. If they say yes, then we would ask, who are you attracted to generally, or what are the genders of the people you're attracted to? Assuming that's a relevant question in the particular, say, healthcare context that they're presenting in. The second component of sexual orientation is behavior. And this refers to whom someone is engaging in sexual or intimate activity with and what type of sexual or intimate activity they're engaging in. Important to note, and again, this has a bit of a healthcare bent, but when we think about sexually transmitted infections, for example, and risk, we know that this risk of sexually transmitted infections isn't conferred by identity. It's not because someone identifies as gay that they have more risk. It has to do with the particular body parts involved and what they're doing with those body parts, right? So someone may be a man who has sex with men, for example, but they may identify that way and their partners may identify that way. That doesn't tell us anything about their particular body parts or what they're doing with their body parts, which is where risk of STIs may or may not come from. Okay. Now, the third component of sexual orientation, in addition to desire and behavior, is identity. And this refers to the range of labels and communities that exist in society that a person may or may not affiliate with regarding their sexual orientation. So some of the more common sexual orientation identities include straight, gay, lesbian, bisexual, queer, asexual, pansexual, And there are many more and more emerging. We have a glossary of terms related to sexual orientation and gender identity on our website that you can check out, lgbtqiahealtheducation.org. It's on the bottom of one of these websites, one of these pages, sorry. And important to note here, as I mentioned with gender identity, that we can't make assumptions about people's sexual orientation based on how they look, based on how they sound, and we can't make assumptions about how they identify, even based on their sexual behavior. For example, there are plenty of men who have sex with men who don't identify as gay, don't identify as bisexual, don't identify as queer, identify as straight. So as far as healthcare goes, for example, when we ask people about their sexual orientation, whatever they tell us is what we document, what we go based on, even if we know that their sexual behavior may not be what we would expect, for example, based on how they identify with regard to sexual orientation. So helpful to think of this in terms of desire, behavior, and identity, not necessarily being the same thing. Another important point to make here is that transgender and gender diverse people can have all possible sexual orientations. We can't predict what someone's sexual orientation or sexual behavior is going to be based on the fact that they're a transgender woman or a transgender man, for example. Now, what does the Q stand for in LGBTQIA+? Q may reflect someone who's questioning their sexual orientation or gender identity. Q can also stand for queer. That's a way many people identify to indicate that they're not straight, but that they also don't necessarily identify with gay, lesbian, or bisexual identities. And important to note, 100 years ago, queer in English meant strange, bizarre, or odd, right? And then mid-20th century, what happened? It became a derogatory term, a slur for particularly gay and lesbian people. And then a couple of decades ago, the community reclaimed this term and said, okay, well, you call us queer to hurt us, so now we're going to call ourselves queer, and we're going to do it with pride, so you can't hurt us anymore by calling us queer. And lo and behold, there are queer studies departments now in colleges around the country. And queer theory is, a discipline taught in universities. So I say that to make the point again that language evolves over time. That being said, we can't assume that everybody's comfortable being called queer. And in fact, some people may not feel, including gay and lesbian people of a certain age, may not be comfortable being called queer at all. It may be the last thing they heard on the playground as a kid before someone harassed them or beat them up. So we have to not make assumptions about how people identify, ask them, and reflect their own language back with them. And that's true for your kids and for their friends as well. I use this acronym LGBTQIA+, and just to kind of round that out, what we use that acronym for, what it refers to, is lesbian, gay, bisexual, transgender, queer, intersex, which I mentioned earlier, having physical sex characteristics beyond traditional notions of female and male bodies. The A stands for asexual, people who primarily don't have sexual attractions to other people or don't find that to be an important part of their identity. And then the plus indicates that we're being inclusive of all possible sexual and gender minority people and communities, okay? And that acronym has evolved. It used to be LGB, and it became LGBT. It would be LGBTQ for a while. And currently that's the most inclusive one, we think, by and large. Some people add to spirit, referring to indigenous gender diverse people to that. Fenway Health's mission has evolved now to use the acronym LGBTQIA+. The only thing I'm sure of is that 10, 20 years from now, it's probably going to evolve and be something different. And that's part of what's exciting and dynamic about this topic as well. Now, to understand the experiences of LGBTQIA+ people in many areas, in policy, in educational programming, in clinical care, in research, we increasingly use what's called a minority stress framework. And the idea here is that LGBTQI+ people from early childhood, developmentally through adolescence into young adulthood and older adulthood, experience in so many cases everyday discrimination, victimization, microaggressions, frank violence, unfortunately, at a higher prevalence than the general population. The FBI in recent years has reported that one of the populations with the highest incidence of hate crimes in the US is African-American transgender women. So that's the horrific reality, unfortunately, many people are living with. And we think of all of this as external stigma-related stress, external stigma-related stressors. And this, over time, developmentally, can take a toll for many people and lead to some disruptions in general psychological processes like coping skills, emotional regulation, interpersonal functioning, having certain beliefs that may be protective in the moment, but that can perpetuate distress over time, like believing it's never going to get better, nobody can be trusted, no one will ever love me, for example. And all the external stigma-related stress can also contribute to internal stigma-related stress, internalized homophobia, internalized transphobia, believing all the negative things that society may say about your sexual orientation, gender identity, gender expression, identity concealment, and expecting rejection in general, right? And these are internal stigma-related stressors that can develop. And all this external and internal stigma-related stress we think is related to what we see in our research, which is a higher prevalence of various behavioral health problems among LGBTQI plus youth, like higher prevalence of depressive disorders, anxiety disorders, post-traumatic stress disorder, substance use disorders in some cases. And all of this we think is related to decreased self-care in some cases, decreased engagement in healthcare, and down the road, a higher prevalence of certain physical health problems as well. Now, there's been an important shift away from just thinking of this as a minority stress framework to talking about and applying a minority stress and resilience framework. So this idea that minority stress experiences can be a crisis, but they can also be an opportunity to develop adaptive coping skills and to thrive and have what some would refer to as post-traumatic growth, for example. And we'll talk more about that. So we think about stigma in three components. One is interpersonal stigma. This is stigma perpetrated between individuals, can start young on the playground and evolve and continue throughout a person's life, can be from a teacher to a student, can be from a member of a healthcare team, as shown here, to a young patient, can be within a family for the child, for example. Second form of stigma that we focus on is structural stigma. And this refers to institutional or governmental policies that may intentionally or unintentionally restrict the opportunities and freedoms of certain groups of people. One example in recent years that's been a big topic in the news was access to all gender restrooms for transgender and gender diverse people. I know this has been a big issue in schools, for example. I know trans and gender diverse folks who've been pulled out of restroom stalls because someone complained about which restroom they were using based on their appearance and called security. A big topic right now, actively in the news, is freedom for children to play on sports teams based on their gender identity, for example, in grade school, in high school. And there's a lot of anti-trans political opposition to children joining sports teams based on their actual gender identity. And these are just a couple of examples of structural stigma. Intrapersonal stigma refers to the kind of internalized homophobia and internalized transphobia I mentioned earlier. These can be hard to shake even after someone is affirmed in their gender identity or comes out in terms of their sexual orientation, and can potentially lead to a lot of shame and social isolation if not addressed in the family, in the school system, and in the community. And just some data here from the US Trans Survey of 28,000 people nationally from every state, including Rhode Island. Of these 28,000 trans respondents, 10% reported a family member was violent towards them because they were transgender, 8% were kicked out of the house because they were transgender. Many experienced serious mistreatment in school, like being verbally harassed, physically attacked, or sexually assaulted because of their gender identity, and 17% experienced such severe mistreatment that they had to leave school. Children of sexual minority parents are often very vulnerable to poverty as well. African-American children in gay male households have the highest poverty rate of any children in any household type in the US, and the rate for children living with lesbian couples is extremely high as well. Coming back to the US Trans Survey for a moment, it found that transgender folks are much more likely to live in poverty compared to the general population, have much higher unemployment than the general population, much lower home ownership than the general population, and much more likely to experience homelessness in their lifetime or even in the past year. And this is in the context of pervasive familial discrimination, as we saw, educational discrimination, employment discrimination, and housing discrimination. There's an Equality Act in the Senate right now that was passed in the House to pervasively provide protections for LGBTQI plus people in basically all facets of life. It was passed in the House of Representatives and is now sitting in the US Senate, and we'll see what happens there. I should say these experiences of stigma can directly adversely impact health. Internalized homophobia, experiencing discrimination, and expecting rejection are associated with increased HIV risk behaviors among men who have sex with men. And enacted and anticipated stigma result in increased delayed, needed, urgent, and preventative care in a sample of over 2,500 transmasculine people in a study done by the Fenway Institute. So people won't go to seek care because they anticipate being mistreated or discriminated against in that context. LGBTQI plus youth are much more likely to attempt suicide than the general population, more likely to experience homelessness, are at high risk of HIV and other sexually transmitted infections. And it's important to think about this intersectionally. Despite an overall decrease in HIV incidence in recent years, which is great, incidence remains high and stable among Black men who have sex with men, and has been rapidly increasing among gay and bisexual Latino men, particularly those 25 to 34 years old. So there's an epidemic of HIV among gay and bisexual men of color that we really haven't made an adequate dent in from a public health standpoint. Word about substance use. Many trans and gender diverse youth report using substances to cope with school-related mistreatment related to their gender identity or expression. And many report using substances to cope with challenges accessing standard of care, gender-affirming medical care as transgender and gender diverse folks. In terms of body image dissatisfaction, trans and gender diverse people have greater body dissatisfaction than non-transgender or cisgender counterparts. Transmasculine youth who do not have an eating disorder still have comparable body dissatisfaction scores to cisgender males who do have an eating disorder. And there can be a drive for thinness among both transfeminine and transmasculine people for different reasons. For transfeminine people who've already undergone an endogenous puberty, it can be a desire to just generally physically be smaller. For transmasculine people, it can be a desire to not have curves that are traditionally associated with more feminine physique. And of course, all this is based on white Western notions of feminine and masculine bodies, just to kind of name that, and that can be problematic in a variety of ways. Important to note, transmasculine and transfeminine people report greater body dissatisfaction not only for gender identifying body parts, but for body shape and weight in general. Important to note, when discussing body image or bodies in general with young people, LGBTQI plus people, but youth in general, it's important to have a very body positive stance and be affirming. And particularly for trans and gender diverse people, to ask them how they refer to their body parts, young folks, and then reflect their own language back. For example, some young people will refer to their chest instead of their breast because they want to use less gendered language. And it's important to kind of ask people that, check in and reflect this language back with youth. This isn't always the easiest thing to talk about, but much higher prevalence of serious psychological distress among trans and gender diverse youth compared to the general population, and 40% lifetime suicide attempt prevalence compared to the general population, which is almost a tenth of that. And this is higher than for any other studied population. It's important to note that risk of attempting suicide decreases significantly when trans and gender diverse people are able to access gender-affirming medical care. So it's important to think about gender-affirming medical care as life-saving treatment for transgender and gender diverse youth. This risk also decreases with strong family support. So strongly supportive families in very good research studies are a predictor of mental health outcomes comparable to other youth, of academic performance comparable to other youth, to later life outcomes comparable to other youth. So it is such a strong determinant. And that's why so much of our work focuses on family systems efforts, right? Working with families. We have groups specifically for parents at Fenway Health, parents of LGBTQI plus youth or trans and gender diverse youth. They're excellent resources, including PFLAG, National Organization for Parents and Families of LGBTQI plus youth, including chapters in Rhode Island and in Providence. So if you're not already connected to them, they do wonderful, wonderful work. And important to note, it can be hard enough to find care teams who are confident and competent providing gender-affirming medical care. Despite that, people often encounter barriers to insurance reimbursement for hormone therapy or for surgery, even though these have been considered medically necessary treatment by the American Medical Association since 2008. So a lot of challenges at different steps in the process. Suicide risk is much lower in the general population, 4 to 5%, depending on the study you look at. For presumed cisgender or non-transgender sexual minority adults, the lifetime prevalence is 11 to 20%. And for gender minority adults, depending on the study you look at, it's 40 to 41%. So it's higher than it is for presumed cisgender sexual minority adults. And as I mentioned, many people in the US Trans Survey report negative experiences with healthcare providers, like being verbally harassed or refused treatment because of their gender identity, not seeking care that they needed due to fear of mistreatment, and not seeking care simply because they couldn't afford it. And important to note, for minors, you need consent from all the parents or guardians in the picture to be able to access gender-affirming hormone therapy or surgery, which is one of the important reasons for doing a lot of family systems work, because parents don't necessarily understand that to have a healthy, happy, thriving child, this care is really important. So we do a lot of family education along those lines. From the US Trans Survey, again, in the preceding 12 months, 48% of respondents had thoughts of attempting suicide, 24% made a plan, 7% attempted suicide. And of the 40% who attempt at any point in their lifetime, 34% have their first attempt by age 13, and 92% have their first attempt by age 25. So this is really the age we want to be very attentive in terms of risk of suicide attempt at. And if we can help kids get through childhood, adolescence, and this period of transitional aged youth, their risk of attempting suicide is much, much lower once they reach adulthood. This is a study we did, published last year in JAMA Psychiatry, looking at the relationship between conversion efforts and suicide attempts. These are gender identity conversion efforts. They're also sexual orientation conversion efforts. These are efforts to change someone's gender identity from transgender or gender diverse to cisgender. There are also efforts to change someone's sexual orientation from gay, lesbian, bisexual, queer to straight. And we did this with the US Trans Survey. We found that 14% of trans and gender diverse people in the US at some point in their lifetime had been exposed to gender identity conversion efforts. And exposure to conversion efforts is associated with more than twice the odds of attempting suicide in one's lifetime. And if you're exposed to conversion efforts before age 10, that's associated with more than 4 times the odds of attempting suicide in your lifetime. Interestingly, there's no difference between conversion efforts performed by a religious advisor versus secular type professionals. So it's not the religious component that's dangerous, it's any effort to change someone's gender identity from transgender or gender diverse to cisgender. We published the study later that year. The American Medical Association cited it in a resolution they passed in support of a federal ban on conversion efforts. And a year ago, exactly in June of 2020, the United Nations cited this study in a resolution they passed in support of an international ban on conversion efforts by the UN General Assembly. Neither of those things have happened, but these are just statements in support. There are efforts at the state level across the country to pass bans on conversion efforts, given how harmful they are. Less than half the states in the country have these bans, so it's a very active area of legislation and advocacy. This is another study we published last year looking at pubertal suppression for transgender youth and risk of suicidal ideation. So pubertal suppression is the use of what are colloquially called puberty blockers, gonadotropin-releasing hormone analogs is what we call them, medications that can press pause on puberty in 10 or stage 2 of puberty or early puberty, so that trans and gender diverse youth can kind of explore their gender identity and don't develop secondary sex characteristics that don't align with their gender identity, because that often contributes to really dramatic increased distress and unfortunately increased risk of attempting suicide at that stage. So press pause on puberty. Kids do need to go through puberty in a timely way. Otherwise, their peers are psychosocially developing, ahead of them, and it's not good for bone growth to not go through, bone health to not go through puberty. That being said, you want it to be a puberty that aligns with the child's gender identity. So you can then induce puberty with testosterone or estradiol that aligns with the child's gender identity. That being said, in this study, we found that only 2.5% of respondents who desired pubertal suppression ever received it. So most people who wanted this medication never received it. And those who received pubertal suppression, compared to those who desired it and did not receive it, had lower odds of lifetime suicidal ideation. So these are very beneficial medications. And we published this in January of last year. The next day, the State House in South Dakota moved forward a bill to basically ban access to gender-affirming medical care for minors in South Dakota. And now most states in the US have a bill at some point in progress to try to either criminalize access to gender-affirming medical care. So the prescribing physician, for example, would go to prison for prescribing it. In other cases, it's not criminalized, but you'd lose your medical license. And many of these attached to them are provisions to report the parent for child abuse for trying to get their child connected to this care. So there's obviously it's obviously very politicized. There's a very low knowledge fund among policymakers, in the general public, and certainly among some clinicians as well, where this isn't part of the standard curriculum, medical education training, for example. So we have our work cut out for us, and there's a lot of advocacy to try to expand access to this medically necessary care rather than restricting it. This is a study we published a month ago in the journal JAMA Surgery, and this is with the same large national data set. We found that people who desired gender-affirming surgeries and accessed them, compared to people who desired gender-affirming surgeries but didn't access them, had improved past-year suicidal ideation, past-year smoking, past-month psychological distress. So it's the same theme of better mental health, among those who are able to access gender-affirming medical or surgical care. And here are some data from that study we published. So how do we overcome these many barriers that I've described to equity for LGBTQI+ youth? First thing we can all do is anticipate and manage expectations. LGBTQI+ youth have a history of experiencing stigma and discrimination in many settings, including in the home, at school, in community, in healthcare settings. So don't be surprised if you're speaking with a young person and make a mistake and the young person becomes upset. Don't personalize the reaction. Apologize when a young person becomes upset, even if what you said was well-intentioned. Say, I'm so sorry, I didn't mean to be disrespectful, and you can correct yourself. And that's a great way to diffuse a difficult situation and reestablish a constructive dialogue. Pronouns are a critical part of creating an inclusive and affirming home environment, school environment, community for trans and gender diverse youth. Many people's pronouns are ones we're more traditionally familiar with, like he, him, his, or she, her, hers. Increasingly, many people's pronouns and many young people's pronouns are they, them, theirs in the singular for non-binary people. So you'd say they are in the waiting room, the doctor's ready to see them, that chart is theirs, for example. This may take practice. You may not be used to using it in the singular. A lot of people get tripped up on the grammar. That's part of the process. You just want to practice and apologize when you make mistakes. It's now officially in the dictionary as a pronoun in the singular. In fact, it was the Merriam-Webster word of the year in 2019. It was they, them, theirs in the singular. So language is, really evolving based on society acknowledging the existence of gender diversity, which is great. There are also many pronouns developed by and for non-binary communities, like Z, here, here's. So you'd say, for example, Z is in the waiting room, the doctor is ready to see here, that chart is here's. And at Fenway, where we provide care, we'll wear pronoun pins on our lanyards, like the one you see here, to normalize the fact that this is a standard part of how we introduce ourselves. We don't make assumptions about anyone's pronouns. The same way you wouldn't see a kid and start calling them Richard, assume that their name is Richard. You also can't look at a kid and assume what their pronouns are. We need to ask and use the pronouns that people share with us. This is an example. These are demonstration videos we make through our education center. This is in a healthcare context, but it applies generally in community as well, to give you a sense of how we try to model these sorts of conversations.
Hi, Dr. Russell. Kai's in the room. I have Kai's chart right here.
Thank you.
Hello, Kai. How are you doing today?
I'm good. How are you?
I'm well, Kai. Last time we met, I recall your pronouns were he, his, him. Now, I don't want to make any assumptions. I always like to check with my patients again. What are your pronouns?
Thanks for asking. There's Z, here, and here's.
Okay, great. I'd like to make a note and let my other staff know. And could you spell those for me?
Sure. ZEHIRHIRS.
Okay, great. And please let me know if I make any mistakes.
Oh, no problem. I will.
In this scene, the clinician affirms the patient's gender identity by asking about any pronoun changes since the last visit. The clinician is also honest about the fact that these pronouns are unfamiliar to her, and she asks the patient to correct her if she makes a mistake. In addition, the clinician makes sure to record the pronouns in the medical record system so that the other staff members will refer to the patient correctly.
So as you can see, it's not rocket science. It's about having a process rooted in cultural humility, where we listen to young people and ask them how they identify, ask them what name they go by, ask them what their pronouns are, and reflect their language back in an affirming way. In terms of discussing gender identity with children and adolescents, for young children, say 3 to 12 years old, we could say something like, some kids feel like a girl on the inside, some kids feel like a boy on the inside, some kids feel like neither, both, or someone else. What about you? How do you feel on the inside? There's no right or wrong answer. When we're working with adolescents, we may phrase it somewhat differently. Ask, what's your current gender identity? Many of them know that term these days. Some teens feel like a girl or a woman on the inside. Some feel like a boy or a man on the inside. Some feel like neither, both, or another gender. What about you? There's no right or wrong answer. And we're aware in healthcare that if we're having this conversation and a parent or guardian is in the room, that may bias the answer. Or if a form is filled out in the waiting room, that may bias the answer as well. So the American Academy of Pediatrics, from middle school on, recommends having part of a pediatric care visit just with the patient themselves so that we can, have some candid conversations, not just about gender identity or sexual orientation, but a range of things where we're more likely to be able to help the young person if part of the visit is done with just them. With pre-adolescent patients for sexual orientation, standard screening question or interview question could be, have you ever had a crush on someone? Was this crush on a boy, a girl, both, or someone of another gender? For adolescents, are you physically or emotionally attracted to boys, girls, both, neither, another gender? Are you not sure yet? And same thing in terms of parent or guardian in the room and wanting to do that ideally with the young person on their own. This is an example of how interactions may go when a parent and child come into a care setting and some of the conversations that might happen with a clinician.
Hey, how you doing?
Hello. I'm here for my child's appointment. The name is S. Souza,
Sure, could I get the date of birth?
August 12, 2008.
Okay, great. So I just have a few forms for you to fill out before we take you in, but feel free to take a seat and bring them back when you're done.
Okay, great. Thank you.
Yeah, no problem.
So, Sasha, I want to ask you a few more questions, okay?
Okay.
Can you tell me, do you feel like a boy or a girl or both or something else? There's no right answer.
She keeps telling me she's a boy and she doesn't like girl stuff, so we let her go by the name Sasha. And I like it because it could be either for a boy or a girl. But I don't know, I think she might just be a tomboy and she wants to be like her big brother.
Mom, I am a boy.
Sorry, honey. It's just hard for me to understand.
Thank you for sharing that. I do want to ask Sasha, what do you say, Sasha?
I'm a boy.
And how long have you known you're a boy?
I don't know, a long time?
And Sasha, when we talk about you, do you want us to call you he or she?
He.
Thank you, Sasha.
In this scene, the registration form provided an opportunity for the parent to share information about her child's gender identity and pronouns. This information was then used by the clinician to ask appropriate, respectful follow-up questions about the child's gender identity and pronouns.
A lot of what we try to do is be aware of the embedded gendered language assumptions in how we talk that we've all been socialized to have in verbal communication with one another, and to unpack that and think about ways we can say the same things without having inherent gender assumptions in our language. Again, we can't tell what someone's gender identity or sexual orientation is based on how they look or how they sound. So instead of saying something like, how may I help you, young man, or how may I help you, young woman, to just say, how may I help you, and be just as warm and welcoming. Instead of saying he or she is here for his or her appointment based on how someone looks, in our field, we would say something like the patient's here in the waiting room. Instead of asking a young person if they have a boyfriend or a girlfriend based on their gender identity or based on how they look or sound, just asking if they're in a relationship, for example. Instead of asking a young person what their mother's and father's names are, which would assume that everyone has both a mother and a father, you could ask what's your guardian's name, or what's your caregiver's name, or who are the grown-ups at home. For example, not everyone comes from a household with a mother and father. Some people have two moms, some people have two dads, some people have a single mom, a single dad, parents who may not identify in a binary way, or may have a guardian and not a parent per se. So it's really about universal design in our language that's going to be inclusive of as many people as possible. We try to avoid certain clearly outdated terms when we communicate, even though we can't keep up with all possible terms that exist. For example, the term homosexual in English was a term imposed on sexual minority communities by the medical community. So instead, we reflect back the language that a young person or a person in general themselves would be using, like gay, lesbian, bisexual, or LGBTQIA+. We don't use the term transvestite anymore, which is a term used for someone who wears clothing traditionally designed for a person of another gender. It doesn't have to do with gender identity per se. And we don't use the term transgendered, ending in ED, which makes it sound like there was an event that made the person transgender, which is not the case. So instead we use the term transgender ending in ER, and it's always an adjective, never a noun. So we'll say she is a transgender girl, or she is a young woman of transgender experience, rather than saying she is a transgender or those transgenders. So it's always an adjective, never a noun. And we avoid the term sexual preference or lifestyle choice. Instead, we use sexual orientation to convey that this is a profound, important part of a person's identity and not a frivolous choice that they've made. We can create a culture of accountability in our homes, in our communities, in our schools. We all have to work together to do so, and not be afraid to politely correct people if they make insensitive comments. You could say something like, those kinds of comments are hurtful to others and don't create a respectful community. Access to all gender restrooms, we can advocate for this in our communities and our schools. Basic part of people being safe and able to navigate the world freely and comfortably. In our field and in many fields, there's a move to systematically review forms, for example, to make sure that these are inclusive of people of all sexual orientations, gender identities, and all families. So instead of forms using terms like mother and father, we replace them with parent or guardian. Instead of husband, wife, we use terms like spouse or partners. Instead of marital status, relationship status. Instead of family status, terms like blood relatives. Instead of using terms like nursing mother, to use the term currently nursing, since there are transmasculine people who are delivering babies and chest feeding. Instead of having sections on forms that say female only or male only, like OBGYN questions, that may lead someone to inadvertently skip over those questions, you could just allow the patient to choose not applicable, so they don't inadvertently skip over questions that may apply to them. We all have implicit bias. We've all been raised in this society, including those of us who are LGBTQIA+, have internalized homophobia and transphobia. So we do a lot of work with all our staff to become aware of their own implicit bias, how that adversely impacts communication, rapport, decision-making. And we do that with case scenarios that illustrate how implicit bias can creep up in our work and day-to-day interactions. So these are just some resources we published in that regard. And we do a lot of work engaging community in the life of our healthcare organizations and institutions to make sure that the decisions are reflective of the needs and priorities of LGBTQI+ people, having advisory boards that include LGBTQI+ folks, community satisfaction surveys, peer support and navigation services, and sponsoring events like Pride this month in June, Transgender Day of Remembrance in November, Intersex Awareness Day in October, and so on. Really important to enhance the resilience of LGBTQI+ youth. It's not all bad, right? This is a community with enormous resilience that's overcome tremendous obstacles, achieved greater and greater integration into the mainstream fabric of US society in just a few short decades. Last few months, we have our first out gay transportation secretary in the federal government. Assistant Secretary of Health and Human Services is a transgender woman, second most powerful person in healthcare in the US. And we can help particularly younger people feel connected to that resilience in the community. That can be enormously empowering. So with that, I will stop. We have a few minutes for questions and discussions, and please feel free to be in touch with any questions moving forward. You can email us at education@fenwayhealth.org. Thank you for your time.
Does anybody have any questions? I actually have one, Dr. Keuroghlian, that we get asked a lot, and that is how parents can help. What tips or advice would you give to parents who want to help their child in a coming out process, especially when one parent is much less accepting or intolerant? And so it ends up secrets and being kept. And what advice do you give to those parents?
Yeah, it's admittedly a very difficult situation, one I personally had growing up, and luckily everybody's come around now and is extremely supportive and loving. It takes a lot of patience on the part of the accepting parent to continue to try to patiently engage the other parent or guardian who maybe hasn't come around yet. I would really encourage you to connect with PFLAG, the organization I mentioned that has very active, robust chapters in Rhode Island as well. This is what they're specialized in, what their expertise is, working with families and all these very complex dynamics that can be very painful for the child and for everyone involved, including the parent who is not yet accepting. That's a very painful position for them to be in, because they're really missing out at the end of the day in terms of having these very joyful experiences with their child and their family. And it's a very long arc, but Parents often get there. It can take years, and you can very much be there for your child through that, while being careful to not create splits and still try to figure out what kind of relationship a child and the parent who isn't fully accepting yet can still have, even if this aspect is one that they can't necessarily bond over and celebrate together yet.
Thank you. We have asking you to repeat the name of that group, the support group.
Absolutely. It's PFLAG. I'll put the acronym here. If you just Google it, you will find their website, and they have very active chapters and resources in Providence and Rhode Island more broadly.
And somebody asks, my transgender daughter is out to my husband and I, but is afraid to come out to extended family, thinking they may not understand because of their age. Any suggestions on how to assure her that her grandparents love her?
Absolutely. It's a difficult situation to be in. I think you never want to pressure anyone to come out before they're ready to do so. You want people to do it at their pace on their own time. You can explore with them what their concerns are about how their family members will react. How they'll feel if a family member doesn't have an ideal reaction, and ask them if they would like you to, or give you permission to kind of negotiate the relationship or have a conversation with that family member beforehand. But I certainly wouldn't disclose it if they're not ready to. And that's fine. If they're only ready to be out to certain family members or people in their life, that's okay. It's not a race.
Thank you. Any others? Okay. People were asking about the availability of your slide deck, and we will make that available on our website. Well, thank you very much, Dr. Keuroghlian. Another really enlightening and wonderful webinar. We hope to have you back in the fall.
My pleasure. Thank you so much for having me again. It's always a delight, and please feel free to connect with our center at any time, and looking forward to connecting with you again after the summer. Nice summer to all.
Yeah, thank you all for coming.